Welcome to AETCM, the Emergency Medicine Channel. Today I'll be presenting a case of a 65-year-old male who presented to ER with complaints of left upper limb and lower limb involuntary movements, vomiting episodes, and lethargy and slurring of speech.
Okay.
Patient, on initial 10-second assessment, a patient was drowsy but arousable, not oriented to time and place. Airway was patent, no gurgling of sounds or stridor. Breathing, air entry was bilaterally equal. Saturation of 98% on room air and respiratory rate of 22 per minute. Circulation wise, pulse rate was 118 per minute with BP of 120/70 millimeters of mercury, CRT of 3 seconds. Disability wise, GCS was E3, V4, M6, pupils equal and reacting to light. Patient had involuntary movements of left upper limb and lower limb intermittently, and GRBS was shown as high in the monitor.
Okay.
And exposure wise, temperature was 100 °F.
Okay.
At this point of time, we put a 18 gauge IV cannula and injection PCM, 1 gram IV stat was started.
Okay.
And also 1 pint NS IV bolus was given. And adjuncts to primary survey, ECG was taken which showed sinus tachycardia.
Okay.
VBG taken showed pH of 7.39, bicarb of 20.3. Potassium 3.3, lactate of 2.5, sodium 131, creatinine of 1.6,
Okay.
anion gap of 50.
Okay.
And CBC CRP was also taken which showed total count of 19,000 with CRP of 130. And coming to secondary survey, patient 65-year-old male, known case of type 2 DM, hypertension, dyslipidemia, CVA with right hemiparesis 1 year back. Presented with complaints of left upper limb and lower limb involuntary movements intermittent since 2 days, and he also had associated vomiting episodes since 3 days, and he had lethargy with slurring of speech, and he was unable to sit without support since 1 day. And there was no any history of cough with expectoration, fever episodes, abdominal pain, chest pain, loss of consciousness. He was on human mixed-art and Silacar, atorvastatin, clopidogrel. Okay. On examination wise, there was no pallor cyanosis, clubbing, edema, lymphadenopathy or icterus, and systemic examination wise, CNS wise, GCS was as we said E3, V4, M6, pupils equal reacting to light. Power of left upper limb, lower limb was 5/5. Whereas right upper limb, lower limb was 3/5. He had residual deficit of the previous CVA, and deep tendon reflexes were 2+, and CVA, rest of the examination was normal. Chest air entry bilateral equal.
What is your provisional diagnosis?
With this, we had suspected.
You can tell me the differential diagnosis 1, 2, 3, 4, 5.
Hyperglycemic state, mostly hyperosmolar hyperglycemic state you are suspecting.
So first of all, a patient who is having a seizure history, who is having previous history of CVA, coming to the ER with seizure, with the right-sided weakness, left-sided, right-sided weakness, I'll suspect as an intracerebral hemorrhage or a stroke as the first differential diagnosis. That will be my first differential diagnosis. What has happened here? You have know the diagnosis and you are telling it as the first diagnosis. That so you should always remember what are the common things that you need to think in first. So the first will be always with the who is on an antiplatelet therapy, 2-day history of weakness is there, then intermittent seizure. The first thing we need to think whether it's a cerebrovascular accident. That should be our first differential diagnosis.
We had suspected that and we took MRI stroke protocol also. It was there was no any acute infarct or IC bleed.
Okay. Then once you rule out a structural abnormality to the brain, then you need to think is the metabolic abnormalities. Among the metabolic abnormalities, the classical presentation where you look, the first one you have to think is hyponatremia. So that is the most common one which will present with seizure. But again, a focal deficit. Whenever you say a focal neurological deficit, usually not classical with hyponatremia. You can have generalized tiredness, generalized bilateral weakness, whole body weakness, all those things. A focal deficit is unlikely to be seen in hyponatremia. So, overall you can have focal deficits. What are the differential diagnoses for a focal neurological deficit? One is stroke. We all know stroke, cerebral pathologies like tumor, intracranial tumor with edema and all those things. What are the metabolic reasons where you can have focal neurological deficit? Or metabolic or maybe medical reasons. Primarily the brain is okay, but hypoglycemia, the most common one is hypoglycemia. Then Hyponatremia will not cause. That's what I am saying. Focal deficit. Hypokalemia, you can have focal neurological deficit. Yes, you can have bilateral lower limb weakness, bilateral upper limb weakness, and reflexia. All those things can be mimicked.
Todd's palsy.
Todd's palsy, that is very important. Can it be a Todd's palsy? Because he has intermittent seizure episode, and he was having after that, maybe in between episode, he is not regaining. We have to think in that terms. Then, migraine, hemiplegic migraine. So these are the other GBS and all we know, but this I am just telling what are the other non-CNS pathologies that can present like this. Is all those things we need to suspect. So again, this patient we have ruled out first stroke. The next thing, why he is developing seizure? That is the question in our mind. Why he is developing a seizure? The most common reason at this age, there can be two possibilities. One is metabolic or other old stroke, maybe because of the gliotic changes. So these are the two possibilities that we need to consider in this patient. So we have got a reason in front of us, that is hyperglycemia. So hyperglycemia, above what level usually they will present with seizure? Usually above what level? Whenever you say hyperglycemia, anything above 200 we can call it as hyperglycemia. So usually we cannot predict when is that seizure threshold. Might be some 250, maybe for patient from 300. But classically when you see this called as hyperglycemic related seizure, we see it is above 500. So the classical patients who is coming with hyperosmolar hyperglycemic state and all those things, we will see it above like 500. They are having this hyperglycemia related seizure. So what is the peculiarity regarding hyperglycemic seizures? When we have different types of seizure. You have tonic-clonic seizure. You have the generalized tonic-clonic seizure. You have the focal seizures. You have absent seizures. So what is the peculiarity about the seizure that you see in hyperglycemia? When you have described that as the patient complaints. So it is coming intermittently. It is coming intermittently and you only affecting one part of the body. In between it is coming and it is going. So usually when you read something called as in seizure disorder, that is called as epilepsia partialia continua. So that is one thing. Partially it will come and later on it will again come. Usually it will happen in metabolic disorders or brain disorder, and also it can be seen in hyperglycemia. So that is a classical description that you need to remember. What are you said from the history? Intermittently it is coming and after that it is resolving. And most importantly, whether his sensorium is going during that time. Whether he is losing his sensorium.
No, same sensorium.
The sensorium is reserved throughout and the sensorium is not dropping and he just had a focal seizure and is suddenly regaining. When you look into a GTCS, the classical presentation, they will have like 20 to 30 minutes. They will not be regaining. It will take a longer time for regaining consciousness. So whenever you have this presentation, even hyperammonemia can have this presentation. All this electrolyte metabolics, classical for hyperglycemia, intermittently it will come and it will go. So that will be the presentation. So now the issues, what we have found out in this patient, he don't have any seizure. He have a lot of metabolic abnormalities in terms of hyperglycemia. And what else he has?
Patient
you said regarding HHS as your differential, hyperglycemia or hyperglycemic state. So how will you diagnose an HHS?
HHS we diagnose.
What are the criteria for diagnosing? That's the question.
Okay. We have to check the pH. pH should be more than 7.3. Then bicarb should be more than 50.
Okay.
And there should be usually no anion gap. High anion gap will not be there.
You can have some amount of anion gap.
And it was elevated, then there will be high anion gap related to that.
Okay.
Then
so primarily you are ruling out a diabetic ketoacidosis.
Yes,
no ketoacidosis, and sometimes ketones can be present because of the dehydration. So the most classical criteria, pH not very low, not less than 7.3, and bicarbonate usually above 50. So these two things you can consider, and sugar level usually
600 to 1000.
Classically it will be very high, like 500 to 600, 700, 800, and it's most commonly seen in type 2 diabetes mellitus. When you see diabetic ketoacidosis, when you read the definition itself, is the first line is the relative insulin deficiency. So relative insulin deficiency has to be there in diabetic ketoacidosis. So whether for a type 1 patient, definitely there is an insulin deficiency, or a type 1 patient who's taking insulin has skipped the insulin, or the patient on insulin have skipped insulin, then only you can call it diabetic ketoacidosis. Here the problem is that hyperosmolar hyperglycemic state. Previously it was called as hyperosmolar non-ketotic coma, HONC. It was the previous, now HHS. They have renamed it as hyperosmolar hyperglycemic state. So what is the pathophysiology in HHS? How does an HHS develop in a patient, and how does the seizure activate? Seizure, it's a separate entity. It is causing irritation to the brain, especially in elderly patients who will be having less threshold for seizure, and on top of that he is developing, and also we need to look in for whether there are any other factors attributing to the seizure. So what are the common factors which can attribute to a seizure in an elderly patient? What are the triggers for a seizure? Fever, okay. Any sepsis, fever, especially fever, even if there is no CNS infection, a fever itself can cause. Then dehydration, like what do you see then?
Decreased sleep, lack of sleep.
Lack of sleep causing seizure disorder. Already who is having an underlying seizure, they can precipitate. Then
Infection.
you already covered. Then drugs. You have to remember the drugs.
Fluoroquinolones.
Quinolones, the classical fluoroquinolones, and what are the other seizure? Painkiller, tramadol, any of these things. So we should see what is the trigger, or because as the age advances and already he has a gliosis, maybe because of the previous stroke, now he is having a high risk for developing a seizure. So any of these triggers has happened. So I think we have checked for this patient. I remember, if I am right, he had some urinary tract infection,
Yes,
and he was getting treated for an urinary tract infection. So the first thing that I want to check whether he has received any quinolones. But he was not on quinolones, he was put on fosfomycin. So fosfomycin was the sachet. He had a recurrent UTI. So recurrent UTI was there. So the first thing that I wanted to look in whether he had received any quinolones. So that is the reason why it has precipitated the seizure. So that was ruled out. Now you have hyperglycemia, you have pathophysiology for how HHS is developing and how it is different from DKA. It is almost, the pathophysiology is the same. How it is different and how what is the pathophysiology? Can you just
in HHS, usually there won't be complete absence of insulin. There will be a relative insulin levels will be there, and the sugar levels will rise to the extent that the osmolarity of the blood will start to increase, and the brain starts to compensate that by producing the osmoles. Idiogenic osmoles it will start to produce so as to not lose the water out of the cell, so that thing will be, that gradient will be made, so the water doesn't get lost out of the cerebral cells.
Okay, but this mechanism fails, and as a result you will have a lot of water loss. So dehydration is the classical finding that you will be able to see. So when you say diabetes, the classical polyuria. So polyuria phase, there will be a lot of sugar being produced, so there is excess polyuria, so the patient will be quite dehydrated. Now the next thing, the sodium level for this patient was 127. I remember when the ABG 128 or something. So how will you calculate the corrected sodium? So suddenly somebody is coming and giving you a blood gas. 120 is the sodium, and his sugars are 600. So how will you calculate the corrected sodium?
To calculate corrected sodium, we have actually two formulas: Katz formula and Helios formula. In Katz formula, we usually take it as sodium, the original sodium plus 1.6 into how much the glucose level minus 100 by 100.
So that is coming to, with that formula?
That formula, for this patient it was 131 VBG, and it came to 143.8 by Katz formula. In another one, they add it as 2.4 into the that same formula, glucose minus 100 by 100.
Okay.
So that came as 151.
151. So I think the second formula is most reasonable. We are expecting,
that is the latest one.
Yeah, you are expecting more of a hypernatremia for this group of patients.
Yes.
So hypernatremia, why we are suspecting hypernatremia? How does hypernatremia happen in this patient? With
the
HHS?
excessive dehydration.
Excessive dehydration. There is excess water loss. So in the compartment there is excess. There is relatively sodium has not increased, but the water have lost. Because of that reason, the sodium is shown as excess. So the treatment will be rehydrating the patient. Even for HHS, it is the same. You need to rehydrate, or even for hypernatremia, we do the same way only. You need to rehydrate the patient. So the most correct formula will be the second one, 2.4 into excess of difference you need to calculate. So it will come around 151. So 20 difference. So that is the one key thing that what we need to keep in our mind, because seeing 130 sodium, we start treating an HHS patient with a normal saline, we are again going to give extra burden of sodium. So that we have to be very clear, or maybe we need to free water. If the patient was conscious oriented, we can ask him to drink normal water, free water, or you can put a Riles tube and also give free water, half normal saline, and even 5% dextrose if it is just hypernatremia alone. If there is no hyperglycemia, you could have given that also. Okay. So now tell me, what is the plan of this patient? What are you want to give any anti-epileptic agent? That is number one question. Second question, how will you correct the sugar? How will you correct the fluid deficiency? and how will you correct the electrolyte deficiency. So what is the key in this patient or any patient with HHS is the correction of the fluid. So how will you correct the fluid?
We started since initially and 1 pint NS was given, but then we changed it to half NS.
Okay.
And half NS was given at around 200 to 300 ml per hour. We had moderated.
So what is the target that you will set in? What is the how much fluid that you need to give in within this time frame? So when you
first 4 hours is crucial. So first we'll give 1 liter over 1 hour, and after that we can taper it to 200 to 300 ml per hour. And based on the patient's response, if there's no any evidence of any fluid overload, basal crepitations, breathlessness, or any pedal edema like that, no cause for any overload, then we can continue with that higher rate of infusion. And the urine output also should be monitored with, we should maintain it at above 50 ml per hour at least.
Above 50 ml per hour means you are giving 0.5 to 1 ml per kg. I will say it should be maintained above 1 ml to 2 ml per kg, urine output. Some 75 to 100 ml if you are able to maintain that much rehydration, you need to plan accordingly. And approximately it is the double the requirement of what you see in DKA. So DKA like 5 to 6 liters will be enough. Here will be 10 to 12 liters. So that is one key thing that you need to keep in your mind. And again, sodium, you have to be judicious in correcting sodium. When you are aggressively going at, sudden dip in sodium also should not happen. So you are targeting a sodium of around 10 decrease in the next 24 hours.
So usually this should be corrected within 1 to 2 to 3 days. Aggressive correction, if the brain has almost compensated for that by producing that osmoles, we correct it rapidly, then it will cause swelling up of the brain, cerebral edema can occur. So that part we have to be careful about.
Okay, so fluid management you have said. Second one.
Second, we will have to check for the potassium levels. So if the potassium level is less than 3.3, then we will have to start with the potassium correction 10 to 20 to 30 milliequivalents per hour. Correction has to be started. Once it crosses that level, 3.3 to 5.3, that level we can start the insulin correction with potassium correction as well.
I am giving a scenario. Instead of HHS, you have got a patient with DKA and I am telling you his potassium level is 3.5 and his pH is 7.1.
So we'll have to start the patient on insulin itself. We have to give dosage of Actrapid 0.1 units per kg per hour. And first, initially, you have to give a bolus, 0.1 units per kg bolus, then after that, per hour infusion. And also,
so you will start insulin here for a 3.5?
Yes, we'll start insulin. With that itself, in the fluid, we'll have to add the KCl.
See, the most important message that I wanted to give you here is one thing. There is something called as corrected potassium for acidosis. Okay, so usually in acidosis, what is the thing that is happening? Usually you look into acidosis. Hyperkalemia is what we see. But here you see hyperkalemia or hypokalemia with acidosis. So when you correct the potassium, actually potassium is falsely increased in an acidosis. Understood?
Okay.
So I am telling you a 3.5 of potassium means the corrected potassium will be somewhere around 3.1. I don't remember the exact formula. For every 0.1 rise of potassium, you need to subtract 0.1 milliequivalents from the potassium. That's what I remember. There is a corrected, you can just Google it, you will be able to get corrected potassium formula is there. So always remember, for acidosis, there is always a factor of correction for potassium. So when you see hyperkalemia in a patient with acidosis, that is what we are routinely thinking. So 5.1 means it might be somewhere around a little bit on the lower side, but it is 3.5 means the potassium is already very low. So for that patient, you are going to start on insulin therapy, then again your potassium is going to down dip. So there are different school of thought. Some school of thought, you don't start insulin at all unless and until your potassium level is above 4. For in diabetic ketoacidosis, there are, you can think American guidelines, European guidelines and all. So some guidelines, they still say you make it above 4, then only you start on your insulin infusion. 3.5 we feel okay, 3.5 is okay, but 3.5 when you correct the potassium, when we calculate like corrected sodium, we calculated for hyperglycemia. Similarly, corrected for the pH you do, it will be much less. So that you have to be careful. So that is the correction factor for potassium. And similarly, there is another formula that I'll tell you later. So in the next case we'll discussion, we'll tell. Okay.
So for this patient, it was lab value was 3.3. So we had started on potassium correction initially. We had put a EJV and we had started on 40 milliequivalent and 500 ml. So
our concern, sugars can wait. But here there is an additional slight risk because of the seizure. Even you correct the dehydration itself, the sugar will start coming down.
Yes.
So even if you don't give insulin also, so that is the criteria. Where you correct the dehydration itself, the patient's seizure will settle. Then you start on insulin if there is no contraindication, and you follow the classical Delta protocol. But here the requirement, you need to see depending upon the patient. Maybe an additional sepsis is there. The requirement might go up, so requirement might come down, and all those things will be there. So that's regarding the insulin therapy. We all know insulin needed to be given, but we don't want a drastic drop of sugar levels. Also should not be done. So if it is coming down below what level, you need to start on 5% dextrose?
In HHS, usually 250 to 300, we have to maintain the glucose levels. So if it falls below 250, we'll have to start on D5 or DNS. We'll have to.
I'll say 5% dextrose will be an ideal solution for this patient, for HHS group of patients, because we don't want to give again DNS, giving normal saline again. What is the difference between DNS and 5% dextrose?
5% dextrose in water.
5% dextrose is just 5% dextrose. There is only dextrose. When you add on normal saline, when you mix up normal saline with it, with the 5 gram of dextrose added to it, that is 5% dextrose. Simple. 5% dextrose minus NS, 5% dextrose plus NS is DNS, dextrose normal saline. Okay. Fine. So 1, 2, 3. Now you should see what is the reason behind he has developed this HHS. What could be the reason?
Here, patient had high total counts and elevated CRP. And
so sepsis would have been the trigger.
Urine showed numerous pus cells, and urine culture showed Klebsiella.
So you need to treat that UTA also.
Creat also was mildly elevated, AK component also.
Okay. Any other drugs that you wanted to look in for? Like we had a patient in our ICU a few days back where sugars was not getting controlled. Elderly patient again. Steroid, okay then. Antipsychotics, we have to be very much clear. Antipsychotics. Antipsychotics are group of drugs. On antipsychotics, they can come with DKA, HHS and all. So antipsychotics, if anything is there, you need to check in that in the list. So medication, checking the medication list is very crucial, and you said sepsis has to be corrected. And my question will be whether you want to give any anti-seizure medication.
Anti-seizure medication. Since the patient's sensorium, there was no worsening. We had done EEG also, and it showed no any activities of seizure activities. So we had not started on any.
It's actually not needed unless and until you are not finding any structural abnormality or anything in the EEG. We can wait. But if the patient is having seizure, he is going into low sensorium, then definitely he require an anti-seizure medication in forms of a levetiracetam, phenytoin, or whatever be the drugs. So anything else that was happened to this patient or done to this patient? So the problem what this patient had, he had an urinary tract infection, recurrent UTI. So that recurrent UTI triggered for an hyperglycemia. So the hyperglycemia again went on to an HHS, and this hyperglycemia also led to an probable hyperglycemic related seizure, and he was treated for UTI and he was treated for all those things, and what was his outcome?
He gradually improved. Initially serum osmolality was around 362 something, and after that it progressively improved, and it improved to 290. That point it has improved, and also the patient's sensorium, he had disorientation had changed, and he had become oriented.
Okay, so he was discharged.
Yes, and his CRP everything reduced.
Reduced, and he was discharged. Anything else that you wanted to add on regarding the management of any of these aspects?
In DK, actually, if the pH is less than 6.9, we have the provision to start soda bicarbonate.
I'll never start soda bicarbonate.
With potassium.
That 6.9, never start bicarbonate for these things. Where you will start, my question, what are the problems with bicarbonate? 1, 2, 3, 4, 5. Problems with bicarbonate.
Bicarbonate reduces the potassium.
Okay. Then, you think it is a drug which you are giving, you are thinking in terms of increasing the cardiac myocardial contractility. Exactly. So, the problem is that inside the cell, it is further worsening the acidosis. So, intracellular acidosis is further worsening. Whenever you seek potassium, again cardiac contractility, it is going to come down. Then, it is a hypertonic saline. So, when you are giving that much volume overload is going to happen. You are giving like 100 milliequivalents of bicarbonate, that much again you are having to develop volume overload. So the patient can suddenly go into pulmonary edema. So you are already the patient, you are giving a lot of fluids, like 100 milliequivalents, 100 ml means it's an hypertonic saline. Like whatever you give, it will be retained within the intravascular compartment, the majority of the content. So suddenly the patient can go into fluid overload. So it will hypokalemia, it will further worsen the intracellular acidosis. I am not saying the blood acidosis. Intracellular acidosis, it will further worsen, and again it will increase sudden volume overload. So for that reason, bicarbonate is never indicated, and again cerebral edema, the chances again the patient is having higher risk of developing cerebral edema. So again cerebral edema you should not be giving. So there was a product which was supposed to set like 10 years back when we were doing postgraduate THAM. I don't remember the exact full form of that drug. It was said to that it has got equally effective drug as of soda bicarbonate without its negative effect like causing hyperkalemia, like not causing intracellular acidosis, but it didn't come to the market. So where all you give bicarbonate? Bicarbonate is indicated where you have a patient 7.1 pH less than, who has got significant coronary artery disease, who is at high risk of developing a ventricular arrhythmia. You don't want that acidosis to stay for a longer time. Maybe you can think that I am not saying for DK or any other, general acidosis, general bicarbonate management is what I am telling. Whenever you have a patient, you have possibility that he had a chance of developing ventricular arrhythmia, maybe that time you might think like 7.1 less than that and all, you can think of bicarbonate. Otherwise, it is your TCA toxicity. Hyperkalemic cardiac arrest. You can associate a hyperkalemia with cardiac arrest. So these are all the indication. And pH less than 6.9 and 6.8 some textbook books. But unless and until you are any of this problem, bicarbonate should be avoided specifically for DK per se. And not in pediatrics, never. If you are accidentally giving an adult patient, that might alright, but never in pediatric. There is no need to you correct the hydration. Have you seen any patient of pure diabetic ketoacidosis getting intubated? We have treated a lot of diabetic ketosis with even bicarbonate of 5, 6, 7 pH. We never intubate them. Maybe NIV to compensate, but when you are intubating, that is a bigger problem that we are going to face. We are going to create a respiratory acidosis by improperly ventilating the patient. He is compensating adequately right now. He is compensating, he is having adequate, not I am saying compensating adequately, he is having adequate respiratory effort. His ventilation would be something like very high. But when you are intubating and you are putting, again you are increasing the PCO2 buildup. So you are going to worsen the acidosis. So majority of the time, when you see the patient with diabetic ketoacidosis, we never intubate. Unless and until he has got a pneumonia, he has got an hypoxia, which there warrants for another reason for intubation, we never intubate this diabetic ketoacidosis patient. So again 6.9, less than 6.9, you can tell in your theory exam, but don't practice it unless and until these are the criteria that I have said. Like the patient is having a high risk of ventricular arrhythmia, CAD, significant previous arrhythmia history, and that maybe you can early that to how much you wanted to give. You need to calculate the deficit, half of the deficit, and you can give at a slow infusion. You don't give boluses also. If you want to give, you give it as a slow infusions only over like 4. Whatever be the deficit you calculate, suppose it is coming around 250 milliequivalents. You calculate the delta bicarbonate, 24 minus 12, that is 12 is the delta bicarbonate. So 12 into body weight, into total body water, it is coming like 300 milliequivalents of total deficits you are getting. You take half of it, that is 150 milliequivalents, you give it as a slow infusion. So you want to really, or having in a cardiac arrest situation, it's a totally different scenario. But TCA toxicity, don't wait for starting bicarbonate therapy or all this sodium channel blockade toxicity. I can tell, rather than saying TCA toxicity, can you tell me another example of a sodium channel blocker? Which antiarrhythmic drug? Class 1. Which sodium channel blocker? Which one? Which one will cause the sodium channel blockade? Which? Which beta blocker? Can you tell me example of a beta blocker which has got a sodium channel blockade property? Short clock. So that is an again one agent which we can give. So we can name it as any sodium channel blockade toxicity. The treatment is basically your soda bicarbonate. Any sodium channel blocker. That's what I am not saying just bicarbonate. Any sodium channel blockade toxicity you can give soda bicarbonate as an infusion. Okay.